So welcome to this session entitled Cardiovascular Care Reinvented Through AI, as if we had already completed it. I'm Calum, as Chris said. I'm a cardiologist, a basic scientist, and a clinician, and I'm currently Vice Chair for Scientific Innovation in the Department of Medicine at Brigham Health. Our task this afternoon is to delve into cardiovascular care. Cardiological or cardiovascular diseases are going to basically kill probably half the people in this room if they survive long enough to encounter them. We know that the innovation cycle in cardiovascular disease is somewhat prolonged, maybe 10 to 15 years for the drug development, another 12 to 15 years, and many billions of dollars to get drugs into the clinic. And many drugs that have already been shown to have dramatic effects are still not fully implemented, even in the most economically developed countries. What we're going to talk about this afternoon is really trying to think about that entire spectrum, from discovery through translation, all the way down to the reinvention of clinical workflow. And we're really delighted to have an expert panel from all of these areas, including a patient who's experienced a care delivery program enabled by AI. I'm going to ask each of the panelists to introduce themselves before we get on and start digging deep.
All right, thank you. So I'm Sebastian Guth, member of Bayer's Pharmaceuticals Executive Committee and responsible for the Americas region for pharmaceuticals. And I'm really excited to be part of this panel today because in my mind, cardiovascular disease, as you've alluded to, is not only the #1 killer worldwide, but what I find concerning is that we have developed somewhat of a blasé attitude collectively towards cardiovascular disease. And I actually think that we are at an inflection point, and I look forward to discussing that tonight or this afternoon.
My name is Udo Hoffmann. I'm the Chief of Cardiovascular Imaging at MGH. As such, I oversee the advanced cardiovascular imaging, cross-sectional imaging at the hospital. And on my research side, I oversee a clinical research program that specifically considers the role of advanced cardiovascular imaging in diagnosis and improving prognosticability in cardiovascular care. In addition, we have been part of inventing cardiovascular imaging as a marker to advance the speed of cardiovascular trials and drug discovery as well.
Hi everyone, this is Rahul Patel. I'm General Manager for Persistent Systems, where we are focused on creating technology solutions largely around digital and AI technologies applying in healthcare. We have been increasingly focused in reinventing clinical workflow with Calum and team, and creating data access and management platforms for healthcare data.
My name is Heather Bell. I am the former global head of digital and analytics at Sanofi, the global pharmaceutical company. I spent 2 years leading digital transformation at Sanofi across a range of therapy areas, including cardiovascular. And I left 10 days ago to pursue more entrepreneurial opportunities. Yeah, a little DMOB happy, what can I tell you? Mike.
My name is Mike Burke. I'm an independent recording engineer and a patient at Brigham and Women's primary care physicians.
So let's get started. I think we will go with Heather first. The initial question really to set the scene is, where do you see, when do you see it, how do you see AI impacting care in the near future? In chronic disease, but in cardiovascular care in particular?
Yeah, so I think the promise is huge. I think the promise of AI is to make cardiovascular care better, faster, and cheaper. Sebastian and Calum have already alluded. I mean, we know we can do better. That globally, the top 2 causes of death are ischemic heart disease and stroke. Faster, we know in heart attack, in cardiac arrest, in stroke, that every second matters. And cheaper, the CDC tells us that the US healthcare system spends $199 billion a year on cardiovascular disease. We also know that the promise is huge because we have a lot of great data. We have MRI images of the heart. We have ECG recordings. We have data on diet and smoking habits and activity and all of the things that can help with prevention. And that's why I'm so excited about how much external innovation we're seeing in small and large companies, literally across the patient pathway. I mean, from risk identification and prevention to actual diagnosis, often in an acute setting, through to treatment and treatment selection, monitoring, and then to even identification of new treatments. And that can be in Sebastian's pharmaceutical company or in Sanofi, but it can also be new modalities like digital therapeutics. How much of that is affecting care today? I defer to Mike, because I haven't been a heart patient myself. But I think the promise is enormous across the board.
Mike, let's go to you next. Just to set the scene, we've heard a lot in the course of the day so far about how the data that are currently collected in much of medicine are not really structured in a way that feeds directly into AI in an effortless, seamless fashion. You participating in an AI-based program that was actually designed to have a transactional framework where each transaction is identical for everybody who's in the program. But you experienced it directly. What did you find in that program, and how did it impact your care?
Sure. Essentially, just like any patient who sees his primary care physician once a year, I go in and talk for 20 minutes about whatever's important and whatever's been bothering me. And for the last 10 or 15 years, he says, your cholesterol is high, and we should probably do something about that someday. And I said, yeah, we probably should. And then we move on to talking about other things. And then a couple of years ago, out of the blue, I got a phone call from the Brigham Lipid Optimization Clinic. And they said, your name came up on my list, and you're high risk, you have high cholesterol, and this runs in your family, and you're this age, and why have you not been taking a statin, and why haven't you been followed more closely? And I said, I don't know, and we talked about it for a long time. We talked about it for a half hour or an hour, and he was able to explain to me, not in my doctor's office, just how the statin works and how the program would work and what the risks would be and what the benefits would be. And I guess that's how I experienced getting my name up on the list and having my data analyzed.
Thank you. Rahul, can you tell us how you see AI impacting care across? You have a fairly unique perspective across most of the US in terms of implementation of a variety of different digital platforms and AI-based systems. How do you see AI impacting care in the near future?
Promise is huge, but we are just starting, right? I see this is in some ways continuation of specialization that happened in care, which is how a lot of AI initiatives are today started and are getting developed, is very unique atomic ideas are already being proven in the studies, in the research, and some of them are coming into practice. I feel for these ideas to materialize in mainstream, if you will, in terms of impacting in near future, two major things have to happen. One is obvious that we are all working on quite a bit, which is actuating what we really create as a model or idea, and how do we put it in practice, which I think more than me, all of you know, it's not as easy as just implementation, right? For a variety of reasons, governance, validation, regulatory, and to be honest, behavioral as well on the provider side or the management side and so on. The second challenge that if we solve, then we can create good impact in short term is what you're asking, is about looking at AI more from a patient and a biology point of view than just a specific disease condition or situation point of view, right? So in other words, bringing different ideas of AI algorithms together, either from different disease perspective or different longitudinal point of view, from a patient's life perspective, really will help, in my view, to solve the first problem, which is how do you put these ideas in practice better, right? So which is bringing these algorithms and models closer into the care, which is affecting more downstream, or as Mike was saying, once we connect with Mike, right, how are we going to help Mike holistically, as opposed to saying we have one issue we have identified, which is your lipids are high, and now we are managing a lipid. But we all know that as humans, we all have multiple unique problems, right? So the point is, this has happened in other systems, which is invention and innovation happen piecemeal. But at some point, you have to think of system-wide, how it's going to really connect and improve the process as a whole. And in our case, process is the person or the human, right? So I think I kind of jumped into what is needed as opposed to what can impact, but I think they're related, right? That we have, I think we have ideas on deck today, and I think these ideas can come into practice fast if we kind of think this way.
So I think we heard from Governor Baker that the bar for an MVP, a minimally viable product in healthcare, is very high. How do you imagine we're going to do that? Maybe Sebastian, you can address this. How do you imagine we're going to do that across the entire disease space? Let's say we just picked cardiovascular, far less one vertical in cardiovascular. How do you think that, you see that from a pharmaceutical company, how do you see that emerging?
I think it's a great question. I mean, in my mind, I think particularly in cardiovascular disease, the promise is significant because in many ways, cardiovascular disease, I believe we're stuck in the analog age with patients show up in high experience environments, with patients show up in low experience environments. And I think the opportunities I see is first and foremost to essentially make physicians smarter, and significant work is going on as we speak, very tangible work, particularly in cardiovascular disease. And that will ultimately help us address in the short term probably one of the biggest opportunities. I mean, recent post-mortem research has shown that about 10% of all patient deaths are essentially attributable to either late or wrong diagnosis. And I think that's a staggering number, 10%, and is something we can address. I think secondarily, particularly for companies like ours, the promise and the opportunities in research and development are significant. I think in cardiovascular disease today, we run trials the same way we've run them for the last 15, 20, 30 years. We're still having the same endpoints. We're basically doing body count trials, and that's a problem. It hinders innovation. Investments in research and development and cardiovascular disease have diminished over the years. And again, I believe that AI is already, as if I look at my company, our company, impacting the way we work in cardiovascular significantly as we speak.
Perfect. Udo, you've thought a lot from an imaging standpoint, and I know you're not as analog as, certainly not as Sebastian would suggest.
Clearly not.
But you've also thought, I think, quite carefully how imaging can impact clinical trials in cardiovascular arena. How do you see AI impacting your field right now, and how do you see it impacting clinical trials in the near future?
Yeah, so I start just with kind of a joke that kind of illustrates the role of imaging. So what they say 20 years ago, in order to get a neuro MRI, you had to see a neurologist. You need to see a specialist. Nowadays, in order to see a neurologist, you need to have a neuro MRI before he talks to you. So, in this country at least, we're blessed in a way that imaging, highly advanced imaging, is available. Expertise is available in interpretation of these images. And that, of course, is also true for the cardiovascular space. Advanced cardiovascular imaging, echocardiography, SPECT, CT, MRI, there are somewhere between 12 and 15 million per year that's being done. And when you think about parts of the cardiovascular system are also imaged in a chest X, simple things as in a chest X-ray, and an abdominal CT and a chest CT. So, probably in the order of, 150, 200 million imaging exams per year done in the United States. image part of the cardiovascular system. And we know, while we talk about, and cardiovascular disease is a systemic disease, so information on the vascular health of the aorta is also extremely relevant for cardiovascular health. So my hope that I see in AI and the premise of AI is to increase the value of imaging for the healthcare system. And it was extensively discussed in the prior discussion around how cost is really one of the major big hurdles to develop our healthcare system further. So what I think is two things that are going to happen with AI. One, the existing dedicated cardiovascular imaging exams, such as cardiovascular MR or CT, these are very complex exams, and just our CT report is about 5 pages long. We have already started, or it has already started, that we use AI to measure things like left ventricular function or atherosclerotic plaque burden. So I think there is a big promise to make the assessment of markers we know have extreme prognostic importance, have extreme importance of telling the cardiologist which medication this patient needs, is going to be much more efficient. The second thing is, and that's for me even more exciting, it was talked about in a couple of prior panels, we need real patient data. We need objective patient data. Well, imaging gives you these objective patient data every day. And so when you look at a chest X-ray, of course, we have our specific question: does this patient has pneumonia, for example? But of course, there's so much more in a chest X-ray that we can see. So I think AI will also allow us, in a very efficient way, to similar to blood and looking at the genome, to find new markers, new imaging biomarkers that, for example, are marker of health of the patient. We're talking about the concept of biological age, for example, that we can do these things very cost efficient, not with new imaging, not with more radiation, not with more cost, but based on the images we have. So those are the two central promises I see in AI and imaging.
So before I go on to the follow-up on that question, just to remind people, if they get a chance, if they have any questions, please don't hesitate to use the iPad. Mike, we just heard Udo talk about how you can pull information from one scan and use it in another system. One of the things I've always thought about, particularly in the context of our willingness to share data as patients, is what would happen if we were using the data we already share, whether we like it or not, with our internet providers, with our cable providers, with our telephone providers, if we were to use that information to drive our healthcare. How do you think patients like you would respond to that type of use of their information, which is already being used to target them for advertising, for a whole host of things?
I don't know. I suppose I'm squirming. I always feel that a certain amount of information needs to be shared. The eye doctor that I see is not in the same network as my primary care physician, and whenever I see her, I always ask, is my doctor going to get this information? Is he going to be able to know what's going on with my eyes? And she says, well, he'll have my report, but one of the things I wonder is, well, what about the imaging? What about the pictures that you took of my eyes? And but of course, everybody kind of squirms when you say you want to share the information about the car that we bought or
how many hours you were watching Netflix on TV because they've locked you in and agreed to third-party sharing. I mean,
exactly.
You could pursue, right?
That's exactly what I'm saying, is that you wonder, if you think about it, medicine is like expecting Netflix to predict what you want to watch when you're not even a subscriber to Netflix. That's the basic problem. We take data from other people and we try and apply it laterally to individuals. So I always wonder, why is it that we have this disparate view of the same data in different contexts? I think it's an interesting way of thinking about even some of the medical data that we collect. Have we really licensed somebody to, or ask them when we consented to see a neurologist to use the data in a cardiac setting. And of course we have, to a large extent. Maybe the inference is that in many other settings in our lives, we're doing the same, but we're not really getting the value in return. Heather, you were heading off in a specific direction.
I mean, I'm animated about this topic because I think I hadn't thought about it specifically in the case of, if I were high risk and had a family history of heart disease and what have you, right? And I might feel differently about it then. But I'm very private about my data and a huge skeptic about social media stuff. And I do think that when we talk about artificial intelligence in healthcare, as if everyone wants to live the quantified life and be the quantified self and wear a whole bunch of different fitness trackers and share all of this relevant information. Now, the segment of the population that I'm in, maybe 10% of the population rather than 80% of the population. I don't know, right? But we tend to talk as though everyone would like to be quantified, tracked, and to share it wherever possible. And I know for me, I have my squirming reaction to that.
Yeah, but so, I would ask a question to you in a different way. Does your lifestyle history help affect your health?
Absolutely.
Right. So then, from a technology perspective, what's the best way to harness your history?
Oh, I think it's
right.
Genuinely, it's a legitimate question. But I do have an ick factor reaction.
Because it gets, in my view, about all or nothing discussion, right? Right. So the challenge is to figure out what is important that you will be willing to share, but all notions are showing that if we can watch you as much as possible in a private way, then it will. Okay, that sounds very weird, but
Don't go there.
But that will help improve your health outcome. Right? So,
Udo, you don't look like you're squirming that much.
I think there's two very different things. I feel, that I don't think there's, as a patient, for example, I don't feel I would have any concerns about sharing data between healthcare providers. I think what we're really talking about when we talk about confidentiality is sharing it with third parties that are not disclosed at the beginning. Right? I think that is really what we're talking about, and so we do, you do share your data with your insurance company. If you have a life insurance, your data will be shared with your insurance company. Maybe you're not even aware of it, but it happens. But so I think these are two very different things. I think patients. Are very open that their data are shared in between networks, but we think we're talking about the concern is third parties that maybe not be disclosed at the beginning. So.
But we had recently a similar discussion in a family context, and there what it ultimately boiled down to is what do I as a patient get in return? And historically, at the end of the day, the sharing of data didn't really impact clinical care. It didn't really impact clinical decision making. And in my mind, that's what's going to change. And with that changing, the willingness, at least if I look at my family and our individual situation, the willingness to share is disproportionately larger. And therefore, at least my belief is that we're looking at going forward at a time where we will see more patients willing to share data rather than less.
Yeah, I think you're right. I imagine that if we were getting advice continuously rather than episodically once every 45 years, we'd have a slightly different view of how the data get delivered. Let's move on to real-world clinical trials. I think that's an area in the cardiovascular space where we certainly hope that it will be feasible to drop the cost of clinical trials. Have you, in pharma, have you actually seen those trials really deliver regulatory level outcomes? I mean, is that something that you think we're moving towards in real time, or is that something that's on the distant horizon?
So in my mind, it's clearly something we're moving towards. So I think we've seen quite a number of examples in the oncology space. And in my mind, what we want to see more of in cardiovascular care is, or cardiovascular medicine, is the application of similar regulatory paradigms as we see them in oncology. I think in at least if I look at Bayer and what we do, I think there's a number of important sort of entry points. One is actually in discovery. We today, 99% of what we do ultimately does not yield in a medicine making it to a patient. And particularly in silico modeling in the cardiovascular space helps us to weed out increasingly a number of experiments that we ultimately see failing or predict to be failing. Secondarily, and that's what you referred to, if I look at clinical trials, our intent is to reduce the duration of clinical trials by some 40% in bringing trials to patients rather than patients to trials. And we feel that we're well advanced, particularly in the cardiovascular space, in turning that vision into a reality.
Heather, you have some experience in this area. What was?
I mean, very similar themes to what Sebastian has said. You know, on the research and discovery side, we're really interested in integrating different data sources so that you're looking at everything from the genetic to the imaging to the phenotypic to the behavioral and seeing if that can drive new insights towards target identification or better candidate identification. And then as we've heard already this afternoon, I mean, the challenge of clinical trials is time and money, but really time, right? Because we just spend so long in clinical trials, and of course it should be a high hurdle, but we spend 35 to 40% of that time recruiting patients. So even before you get to AI, what can we be doing to recruit patients online, make patients aware of the therapies that we are testing? What can we do, as Sebastian says, rather than hauling people to clinical sites on a regular basis and therefore constraining who can participate because you have to be within commutable distance of a clinical center, and you have to be able to get the time off work, et cetera, or off school. Can we allow people to participate from their living room? And that turns out to be harder than you might think, because you have to have remotely measurable endpoints, and you have to be able to ensure that the person participating is the person you're in contact with and whose data you're getting is really the person who's enrolled in the trial. But I think huge promise here for speeding things up and for increasing the diversity of the participation in these trials. I think a couple of other areas that we're really interested in is, or at least one other area we're really interested in, is digital therapeutics, broadly writ. Software that can produce a clinically validated outcome that may be over the counter, but may actually be prescribed by a physician. I mean, and here you have everything from weight loss prevention of chronic disease like OMADA, which is a 16-week program focused on diet, activity, stress, and sleep, that has shown to help patients lose 4 to 5% of their weight, and that tends to stick for 2 years. And that massively decreases their likelihood over 5 years of getting type 2 diabetes or heart disease or stroke. So that's on the preventive end, but then you may also have somebody post-heart attack who is trying to change lifestyle and reduce risk for a second coronary event, and a similar set of behavioral interventions apply. And so companies like Click Therapeutics have ClickHeart, a digital therapeutic that will be prescribed in their pipeline. And I think it's very interesting to see if that's going to be new modality or if it ends up being add-on to existing drug. I mean, exactly how, and how much people are willing to pay for it.
Mike, this is obviously a very unscientific survey, but if you'd been asked to consent to a clinical trial in the current program, how would you have thought about that, never having necessarily met face-to-face the individual that was trying to recruit you to the trial?
Right. I'm glad that the clinic found me, and I'm glad that I started taking a statin. I'd feel more comfortable if I guess if the information came through my own doctor, but there's a doctor on the team, and I ultimately felt comfortable with them. I would be okay with giving it a try. I also like what Heather was saying just a second ago about having as a patient, maybe an app or a video game where I can put in my information and say, I'm going to do this today, or I'm not going to do this today, and what does that mean for me? Because I almost feel like there's two different pieces of data anyway. There's what I actually do with my life and what I tell my doctor. When I go in, they say, oh, sure, I drink 2 drinks a week, and I probably exercise, I guess, a couple hours a week. But it's different than reality.
Yeah. Rahul, you have a perspective across the country. What proportion of your engagements are on the research side, and what proportion are in the actual implementation side?
I think 75% is still on research side.
Still on the research side.
And it's increased. On actual implementation, interest is increasing, the planning is starting, but yeah, it's largely still research driven. In terms of these new innovative ways to improve clinical workflow or those kind of environments, I wouldn't categorize them purely as AI alone, but in terms of innovative ideas, right? Yeah. But on the other hand, I think our last panel was also talking a lot about data. That's where we see a lot of implementation level initiatives to really start making sense of data in a more efficient way. Because today what's happening, even for research, that every research idea requires end-to-end mapping of what the research needs and collecting, as you are saying, data from all different environments for just particular study or particular initiative. That not only is cost prohibitive, but also it's kind of reduces the pace of research, because for a lot of innovative ideas, you just cannot invest in that entire process that way, right? So we do see a lot of systems already recognizing that as a need to create a much more horizontal way to deal with data, so that you can enable all these ideas faster.
As if everybody who was actually receiving care was part of a system that could actually deliver insights on that care.
That would be one.
Udo, have any clinical trials that you've participated in actually used AI-driven endpoints yet? Where are we in that space?
Yeah, I got to disappoint you there, no. So, right now, for example, just to give you an example, right now with my colleague Steve Greenspoon for endocrinology, we're doing a trial in about 140 sites worldwide. It's a prevention trial for cardiovascular prevention in HIV-positive patients. And it has an imaging component. And of course, standardizing, and everyone's familiar with this here and maybe in the audience, but standardizing all the data elements that we collect, making sure the images get acquired in a standardized fashion, because that's not the case yet in clinical care. It's like building a new system within the system, right? So every site, and we're already working with the ACTG trial network, which does these trials on over many years on a constant basis. But it's still an extraordinary cost to deliver a trial with high quality data. And of course, so in that sense, AI, the workshop recently, they talked about having patients, wearing locators, and cross-map that with healthcare facilities. So whenever a patient in a trial coordinates cross with the healthcare facility, the patient gets a text saying, well, was this did you just visit a family member, or was that your visit? And if so, blah blah blah. So so there are definitely a lot of ways that you could improve the efficiency of these large clinical trials. I think the crucial thing would be to get the clinical care to be more standardized, because that would automatically, make clinical trials less expensive. It's a very complex, it's a very complex system, especially also, thinking that the numbers in these trials are usually large in cardiovascular care, because the event rate, despite on a big picture, that this is number one cause of mortality and morbidity. But on an individual basis, nowadays, the risk is relatively low. So, large numbers. So, in my as a clinical trialist right now, AI is a big premise that has the potential to really cut down on the cost. And I remember many years ago, 5 years ago, the NHLBI said, well, we're not going to do trials where a patient costs more than $5,000 for the trial. I don't think very rarely there are trials that are done nowadays at that cost. So I think we're still, we need AI in a way, but I don't think it's really the AI itself that's the issue, because I think there are solutions, but it's really to, how do you kind of minimize the differences in a way between how you follow a patient in a trial for outcomes versus how do you follow a patient, as routine part of clinical care, because the outcomes we're looking for, myocardial infarction, there are outcomes that clinicians are interested in, obviously. So I think that is more that is the biggest challenge, and AI can be a tool to, of course, facilitate that.
So you're making an argument really for bringing both ends towards the middle, bringing fundamental discovery, translation, and care all into a single system. We're a long way from that, I believe. Sebastian, how do you think that's going to play out from your standpoint?
I actually think, what I heard you say is that the disparity of the diagnostic workup in clinical trials and what we do in clinical care, in standard clinical care, is something we need to bridge. And in my mind, that's increasingly at least areas that we work on and that are becoming real. If I look at our company, for example, we've just been granted FDA breakthrough designation for a software we're developing in the field of chronic thromboembolic pulmonary hypertension, which is a relatively rare form of pulmonary hypertension and often goes undiagnosed. And the basic work that we're intending to bring to commercialize within the next 6 to 12 months, so in the foreseeable future, is essentially an algorithm that latches on to both the EHR records and imaging data and helps physicians to diagnose patients with CTEPH significantly more reliably than it is the case today. And I think it is those examples, those specific examples, that help us sort of marry what's being done in a clinical trial setting and what's being done in day-to-day clinical care, and with that, ultimately sort of improve outcomes and drive, better results for patients.
I have to tell you, I was amazed when I became chief of cardiology to recognize that only 40% of commercially insured, only 60% of commercially insured patients in North America receive a second statin prescription after discharge, which is absolutely stunning. If we're not able to overcome that, we're going to have some difficulty stratifying patients at a molecular level. A couple of questions from the audience. How do you think AI will affect the patient experience? Mike, how do you think it could have affected it going forward?
Oh, well, I'd love to have the data that they already know about me, that my doctors already know about me, all the various doctors that I've seen, pulled together and maybe generate a list. Maybe before my physical exam each year, just to say, hey, you should probably talk to your doctor about these things, and the list could even be prioritized. It could say, you're the guy, you got to talk about these 4 things for sure. And I'd love another list to go to my doctor so that my doctor's prepared for the discussion of maybe some evidence-based practice that says, this medicine would be fine for you, or this one wouldn't be great for you. Because of this other condition, so I'd love to see something like that. I'd love to have information at my disposal and information at my doctor's disposal.
What about the others on the panel? Any ideas from your experiences as patients that you think AI could augment?
So I have not as an experience as a patient, but company I've heard about that is this week is the company I'm most excited about having heard about. It's called Corti. It's based in Copenhagen. Do you guys know this company? So they have taken 1 million conversations with emergency medical dispatchers. So in Europe, 112, but here 911. And they've written a deep convolutional neural network to analyze these conversations, both the actual words, but also noise in the background, in order to be able to better predict, identify cardiac arrest. And they're using this in Copenhagen now, and they were last year anyway in the process of rolling this out across some other European cities and Asian and American cities. And what this does is it's AI that augments the medical dispatcher. So they're getting the call from the person in crisis or from the family member, and they're saying, I don't know what's happened. And the AI uses the experience of the previous million conversations to prompt the dispatcher to ask different questions and identify when there is risk that this is actually cardiac arrest. And studies have shown that the AI augmented dispatcher can identify cardiac arrest 30 seconds faster than the dispatcher alone. And dispatcher alone can do this with 73% accuracy, and augmented, they do it 93%. I think this is fabulous. Like in a situation where literally every second counts, this AI is giving you additional seconds. So, how can this improve the patient experience? It can help them, potentially give them a better chance of surviving.
Survive, exactly.
Rahul.
I'll be a little contrarian here. And again, I come from a bit broader or different views than patient as a consumer, because I have helped build systems about other consumers who are not patients, right? So let me ask a question. How much an individual consumer is worth to Amazon per year, right? I would contend it's much less than any patient is worth to any provider system today, right? Or payers for that matter, right? But you all as consumers know that you are getting great experience with Amazon, right? Now, part of that may be AI, part of that is maybe very, very personalized and specialized as what you're talking about, but largely is about engagement, right? So my experience is that when we are thinking of patient experience, it's about people who they trust. Are they really engaged with the patients or not, right? And I think we can go very advanced and try to keep on thinking what patients should get that they don't have today, like this kind of advanced thing. Mm-hmm. But I think there are so many basic things that industry does with consumers that we don't do. We don't do it well, right? So in terms of the question was how can AI help patient experience? I would just say that how can engagement-based knowledge that exists in the world, if we bring in healthcare, how will it help patient experience? I think there is a lot to be done.
I actually think Mike's point at the very start of this trail was very pertinent, that actually by informing the patient so they can actually be engaged and drive it is really... I mean,
what Mike is describing, what he would like to know, that existed in a consumer world 15 years back.
Yeah.
You go to your profile and you see everything that you're in, right?
Totally agree. Totally agree. In the last few minutes, I thought it would be good for us to each just think quickly about what we see as the challenges for AI from our perspective, making it into the part of healthcare that we touch. We'll go down this way and finish off with Mike. Sebastian.
So in my mind, the biggest challenge is that we have today a very large number of dispersed data sets. We have islands that are highly disconnected, and I think merging some of those islands, building essentially an infrastructure, as Rahul, you described earlier, that allows us to iterate significantly faster than we've done to date is in my world, the biggest challenge that we face and what we work on.
Udo.
Yeah, so data sharing is certainly a challenge, especially, or not especially, but also in the imaging world. We know there are, even for the same class of drugs, for example, it's not uncommon that there are, a number of trials, for example, where imaging data exists, but they're not shared at the moment between the companies, for example, who sponsor these trials. So I think there that has, of course, a lot of challenges, competition-wise, et cetera. But data sharing in whatever form is very crucial for imaging. When you go to the RSNA, which is the Annual Radiology Society of North America, in the last couple of years, you don't hear a presentation without the word machine learning or AI. And while everyone is excited about this, I think, we are at the beginning of, this new, kind of a toy for radiologists in that sense, right? And I would advocate for, putting in place quality assurance criteria, putting in place really an understanding of what constitutes high quality data in this space, because we're going to see a lot of publications that will be coming out over the next years. And while they are, I'm sure, all intended well, there's only going to, the number that is really going to be suited to inform care is probably much lower. So those are, two of the main points I see.
I'd simply add to what you said, Udo, that also preclinical data is amazingly poorly shared. I think if we even knew why drugs had failed,
yes,
we would really be in a much stronger position than we are at present. Rahul, what do you see as the challenges?
So I think challenge to me is how do you use AI to really achieve the outcomes that you are looking for. And to me, it goes through transforming clinical workflow. And what I mean by that is not just about how can you remove the challenges for our AI adoption, but to me, it's much more about thinking of clinical workflow goal is to make it software driven. And AI is a component or a vehicle or a tool as part of that mission, right? So AI alone cannot solve this problem, as we know, because there is so much knowledge that exists today which has not yet become software driven, right? So, I mean, some of the work we are actually doing with you is example of how do you create essentially a mission, right, that, large systems like you would really aim to create basically a software assistance in your workflow that today we believe or we claim it exists, but it doesn't really exist, right? And part of that assistant comes from AI, part of assistant comes just from automation or rules-based knowledge execution or whatever those techniques may be, right? And with that mission, if you solve the data problem as you are talking about, then you have a platform for this, right? Now the key part of data problem is not only ability to collect and access the data, but also to create the information as you're going through this new workflow, right? So data capture is equally important because that's the only way any kind of AI engine will get better and better, right? So I think I'm not outlining a single problem, but I think that's the
whole problem.
That's the way to go. Yeah.
Heather.
Scale. How do you get people to, once you solve all of these problems, how do you get people to adopt this and do it at scale?
Mike, you have the unenviable privilege of closing us out.
All right, sure. I think the patient wants to trust this technology, and for me it was easy because I got some benefit from it. And when I asked some of my friends what the concerns were of having AI analyze my data, I got some kind of simple answers, basically saying they don't want the Terminator to happen, they don't want the machine to be smart enough to kill us or control our healthcare. I think it just needs a face. It needs to be information that's organized and accessible, but it comes to me through a doctor, it comes to me through a person, and it's my decision.
Fantastic. What a great place to finish. I would like to ask you all to join me thanking the panel for an excellent discussion.